Welcome to today's webinar, How Borrowing Medical Debt Credit Reporting Impacts Providers. This is Ashley Myers, HFMA's Client Services Specialist, and I will be moderating today's session. And with that, Steve, I'll turn this presentation over to you.
Well, thank you, and thank you for joining us today. I wanted to introduce our speakers. We've got a great panel here, and this will be a panel discussion. Our first speaker is Leah Dempsey. She is the co-chair of financial services at Brownstein, Hyatt, Barber, and Schreck. For those of you that are not familiar with Brownstein, they are the nation's largest advocacy and lobbying group. Leah is a lawyer and an advocate with a unique ability to bridge policy, financial, and communication laws, as well as regulations and politics. She advises several trade associations within the financial services, housing, and fintech markets. Most relevant for today's topic, she's been actively involved with the legislation surrounding CFPB, as well as previously with 501R. She holds a GAD from the University of Baltimore School of Law and a Bachelor of Arts in Political Science with a concentration in journalism from the University of Delaware. She's also a member of the Maryland and District of Columbia Bar Associations. Joining Leah is Dennis Jones. Dennis is a senior director of revenue cycle with Jefferson Health, which is based in Philadelphia. He's an experienced healthcare leader with broad and detailed knowledge of the revenue cycle, compliance issues, denials management, process and workflow, and uncompensated care. Dennis is a past president of the New Jersey chapter of AHAM. He's a frequent speaker at state and local HFMA chapters, as well as the New Jersey Hospital Association. He's actually been a frequent contributor to the RAC Monitor website and hosts the RAC Monitor Monday podcast. Dennis is a graduate of Penn State University with a degree in health planning and administration and will soon complete his Master of Science in Operational Leadership degree from Thomas Jefferson University. Tim Haag is the president and CEO of State Collection Service. He carries on the family legacy as a third generation of Haag leadership since its inception in 1949. While State was created by his grandfather, Tim has joined the company in 2009. And during that time, he's held various roles, including a sales executive, director of client services, and the vice president of support services. While serving as the president and CEO of the company, it has grown by more than 300%, now employing 700 people and serves major healthcare systems across the United States. Important to this topic, though, with the experience of State, as well as he currently serves as the president of ACA International Board. He's a past president of the Great Lakes Credit and Collection Association, as well as the International Collectors Group. He's also a frequent speaker addressing healthcare revenue cycle and receivable management topics. So before we get started with the details, I wanted to take a step back and say, hey, what do you think so far? Not of what I'm saying, but of the topic. So in your opinion, what does healthcare finance need to be prepared for in the future? Is it AI, government policy regulation changes, and others? And of course, the government regulation policies would include what we're talking about today, as well as issues with CMS, etc. Cast your votes.
Steve, as they're making their votes, there's one thing. You didn't introduce yourself, so I'm going to introduce yourself, and I don't have a bio for you. But this is Steve Beard, our host today, who serves as Chief Business Development Officer here at State. He's been with the company for 15 years. He's been in healthcare for too big of a number to share because I'll embarrass him, but it's about 40, but he started when he was 5. So we're very grateful to have you here today, Steve, and look forward to the conversation.
All right. Ashley, do we have the results? There they are. Look at that. You know, the funny thing is HFMA just did a study in January and asked the same exact question, and it turned out the same exact way. So it looks like 62% of you believe that government policy and regulation changes are the most important option, 34%. AI and other comes in at a whopping 4%. Well, before we get started with the details, Tim, do you want to talk about where we are exactly now in this process with the CFPB, et cetera, and how did we get here?
Yeah, Steve. So we've actually been tracking this. We've heard about this from the CFPB for, Leah, I think it's been probably 2.5, maybe almost 3 years. So we were tracking it. We were meeting with them. We didn't know what necessarily to expect. Um, and then most recently, obviously, we saw the proposed rule come out. We had, I think it was 60 days to respond with questions and comments, and we did have participated in a couple of hearings. And then they did push forward with the 500 and under not being able to be credit reported, and anything over 500 can, but not till after 1 year since time of service. But some of the things that we found that were very interesting is just how how are they defining healthcare? And that was one of the simple questions that we asked. So is that everything? So as an example, if I go to CVS today and pick up a pack of Band-Aids, put it in my credit card, can that not be impacted on my credit report? What if, does that include veterinarian service? And I think Dennis has got a story about that a little bit later that he'll share. And so the scope of healthcare is obviously very big. So we did end up getting back an answer from them, which was, anything human related from a doctor or a hospital, which seemed very vague to us. The other interesting thing is, as we all know, as healthcare professionals, 4 or 5 years ago, there was a trend of getting rid of litigation to collect unpaid medical debt. And prior to that, there were many hospitals out there that did that. There were some bad actors, and won't name those, but many of you know who they are. And so there was some really bad press in, the New York Times and Washington Post, USA Today, all over the place. And so health systems started shying away from that. Then COVID hit, and the courts closed, and most healthcare organizations did not turn that piece of the funnel back on. Well, in this proposed rule, the CFPB was suggesting that how do we asked how would we end up collecting unpaid medical debt if it doesn't have any repercussions? They said, well, you can sue them. But now we're just going to fill the courts with unpaid medical debt in an industry where we were trying to get away from that. The other thing is they put a lot of blame, and Dennis, I think you might mention a little bit about this, is on the incorrect bills, and that the insurance didn't pay the right amount. So we're actually trying to collect money that isn't truly owed. As we know, there is a validation period. We at state take a dispute. It's legally, we only have to take it for the first 30 days, but it's been our tradition. We'll take a dispute at any point in the process, because the last thing we want is to upset a patient, which would then obviously upset our clients. So those are a few things that I pointed out, and we can go from there. So, Dennis, anything you would add to that?
Well, Tim gave me a couple things to talk about there, so I better get to him. In setting the stage for the strange world we live in, there's kind of a healthcare parable. Winter returned to the Northeast this year after a couple mild winters. We had snow, we had ice, and I'm taking my dog. It's a little dog. It's a schnoodle. I'm taking him out. Cyrus, the little schnoodle. I'm taking him out for a walk, and we get out on the front steps, and Cyrus takes off with his leash, and I lose my balance, and I fall and broke my hip. And that's the bad news. The worst news is that I fell on Cyrus and broke his hip as well. So Cyrus and I, it's not a total tragedy. We both have insurance. And we both end up spending 2 days, 2 nights, in the hospital. Not the same hospital. He's in the doggy hospital. But after that misfortune, with both of us having insurance, let me ask the audience, and this is not a poll question, but let me just ask the audience, whose bill do you think was paid by insurance without a denial or without a request for additional information? And when the insurance eventually pays what they're going to pay for the bill, and I get the self-pay balance for myself and my dog, whose bill do you think I should prioritize paying? What's more important to me as a consumer to make sure I clear that debt from my record? And I think everybody out there knows the answer to that question. And it's a world turned upside down. Pay the dog's bills. The hospital bills, the doctor bills, they take a lower priority.
Yeah, Dennis, I'm sorry, in the chat, you're not getting any sympathy at all. It's all
no sympathy.
Yeah.
You would think I fell on the dog, it would have cushioned my fall, but no.
So Tim, the $500 and under is already in place today. And maybe if I take a step back, just a trip down memory lane, HFMA has been all over this topic for quite some time. In fact, when the CFPB first was formed, not first, but it was formed, they said, well, we won't have any overview or purview on healthcare collections. Well, HFMA in their wisdom said, oh, we don't need to bury our head in the sand. Let's be proactive. So in 2016, HFMA created the Medical Debt Advisory Task Force, which Tim and I participated in. And that was updated in 2020, and it was called the Medical Accounts Receivable Resolution Task Force. They just decided to make the name longer, I guess. But basically what it was saying is looking at it holistically. And in fact, in the 501R rulings, this was the task force, the original task force was cited. So that's kind of a trip down memory lane, but here's where we are today. 500 and under is already credit reported. Tim, there was a study that was commissioned by ACA International. What were the findings of that?
Before I get into those findings, I want to go back to Dennis's story, because beyond the insurance piece, you got to the self-pay piece. Now, the interesting thing is, if your balance was under that $500, you're not getting credit reported. The veterinarian, he's going to credit report you. And if you don't pay, he's going to sue you, he or she. So that's the other difference. And that's what we were trying to get from the members of the CFPB is when they describe medical debt, does that include a veterinarian bill? And it did not. But so I'm sorry, Dennis, but you better pay that vet bill first.
Well, that's
Steve, back to your question on the study that we engaged with. So yes, ACA International, along with the Brownstein firm that Leah's at, we commissioned Dr. Negrenis. He's an economist that used to work for the CFPB, so we thought he's the perfect person for it. We pulled a number of data from a number of different ACA members that do medical debt, and the first go around, which was done about a year ago, it had been about 6 months after that they had started the no credit reporting under the 500. What we had found in the data is collections were down 10%, and placements were up by 10%. So it wasn't just impacting on the bad debt side, because if you're seeing more placements, that means there were less people paying in the first 120 days that ended up going to bad debt. We redid that study after a year, and the results pretty much stayed the same. So there is an impact. We talk to our clients all the time. And one of the things when this first started coming up, and Dennis, you were one of them, because, and I might be jumping ahead here, but so many of our clients would tell us, but Tim, this is not going to impact us. We haven't credit reported in many, many years, probably 10 plus years. But the difference is 10 years ago, when you decided not to credit report, you weren't telling the world that you weren't credit reporting. So if they got a letter from us, they assumed this is a collection letter. I better get to this, and I better call them, and I better set up a payment arrangement or payment in full, because I don't want my credit to get dinged. Well, now, over the last year or more, we've seen in all the mainstream media all the attention that this has gotten. And so we have patients today that call us all the time saying, why would I pay this? There's no impact. And that's a scary thing.
So Dennis, as a provider, as Tim mentioned, that doesn't credit report, what are you seeing or what are your feelings on the topic?
Yeah, Steve, we are seeing the impact, and I apologize to Tim for doubting him, when we were first talking about the new regulations, but his point is well made. It wasn't the fact that we weren't credit reporting or taking legal action, which we weren't doing for for sake of the mission of the health system, but also public relations, customer relations. But it's the knowledge that we're not doing that. That the general knowledge is really what's affecting us. We have seen referrals. Referrals may actually be up. As more patients are shouldering the burden of higher self-pay balances. But collections are, even if they're steady, if referrals are up and our collections are steady, our liquidity is down. Mm-hmm. And looking at our statistics, we look at our liquidity, and over the first half, from the first half of 2024 to the second half of 2024, our liquidity went down about 2.5%. And 2.5% is about $900,000 a month to us. And a couple months of $900,000 hits, now we're talking about some real money. So it gets lost if you're just looking at the collections, because referrals are going up. You might think your cash is okay, but if you look at the liquidity, okay, it's that missed opportunity. It's the accounts that you're not getting. It's the amount that's going on to terminal bad debt, and it's just lost to you.
Yeah, I suppose the real issue is the media has jumped all over this, and so it's just the public awareness that it's not going to be credit reported. But if you take that to a next, maybe a quantum leap, but if you take a leap to say, well, are you seeing people that might say, well, why would I even have insurance if nothing's going to happen? There are no repercussions.
Well, on that point, Steve, again, when this first started coming up 2.5, 3 years ago, a few of us met here in Madison, Wisconsin, where home is for me, with our local congressman, and I asked him that exact question. I said, Brian, you pay a lot for health insurance, I'm guessing, as we all do. Absolutely, he said. And I said, so with this rule, tell me, why would we continue to pay, and why not just take that monthly payment, put it into a slush fund for an emergency, and wait until I have that bill that's over $500 to pay it. I also had a very good friend of mine that's in the business. He called his doctor because he was trying to make a payment online, and he's a personal friend of his. And he said, Tom, I'm trying to make this payment, but your system is really confusing. His friend looked at the doctor, said, well, how much is the balance? He goes, $225. He goes, why are you going to pay it? I can't credit report you. This is his own friend. So it was kind of ironic, and I'm sure that happens a lot these days.
Yeah, and Steve, when you talk about why would people have insurance, a lot of people, we see that there a lot of people have come off the Medicaid rolls. I think there was an enormous number, 20 million people coming off the Medicaid rolls. We also have people who might qualify for Medicaid but are hesitant to apply for emergency Medicaid, for emergency services, because they don't want to get involved in the immigration, citizenship, net, and they delay the services or just go without them. But they're playing the game where if you don't have insurance and you're not getting primary care and you're not getting diagnostic care, you're going to end up back in the emergency room with something far more serious, and you're still going to be a self-pay, and it's going to be a long hospital stay instead of a small outpatient or diagnostic stay. So it's hurting us in the short term and the long term. People are deferring treatment, and they're coming back and they still don't have insurance. Now they're in for a big ticket item. We're really using a lot of resources, and our operating costs go up on those patients. So it's just it's a compounding problem.
Right. So we started off by talking about, there's some misunderstandings and really just some incorrect assumptions that in this proposed ruling that has taken place. And Leah, as somebody that is actively involved in this in the DC area and has spent time with legislators and policymakers, tell me, what do you find is the biggest issue in this? Is it just not understanding healthcare? What might it be?
Sure. Well, a couple things. First of all, just one misunderstanding is that this rule is final and in effect. The effective date was supposed to be this month, but there's multiple pieces of litigation challenging it. ACA International is challenging it in Texas, and Cornerstone Credit Union League, as well as the Credit Bureau CDIA, are challenging it in Texas as well. And as part of that litigation, it is under a current stay of 90 days. So there's going to be additional rounds of briefing and additional efforts there. But long story short, because of that litigation, the rule has not gone into effect. So it's not something that people need to be complying with. But overall, I think there is, of course, a sympathy for people with health issues and people that have to pay for medical care. And, when people hear some of the sound bites that came out when this rule was being pushed by the previous administration, they were, of course, sympathetic to some of the arguments about people's medical bills and things like that. But at the end of the day, this actually isn't something that's helpful to consumers. It's gonna, as Dennis and Tim have been talking about, it's gonna have an impact on the bottom line at hospitals and at small doctor shops, particularly those in rural and underserved areas. And that isn't just gonna, that impact is not just gonna go away. It's gonna either, as Tim mentioned, go to the courts, or it's gonna require additional cash up front. And people are going to have to pay that cash up front. They're going to have financing, which could be things like small dollar payday loans that have exorbitant interest rates of well above 36%. So there's all sorts of impacts that this is going to have on consumers. The debt doesn't go away. There's still, it's still going to be there. If you don't pay it, you may not be able to go back to certain doctors in certain areas if it's not emergency care. So all of that, there's a lot of confusion in Washington about this, and a lot of confusion about what this does, that it doesn't necessarily make your debt go away. It just really kind of hides it from your credit report. There's also a lot of misinformation that this is targeting the debt collection industry. And as Tim mentioned, this kind of false, bogeyman out there of people reporting these fake debts. That's, first of all, as everyone who works in the industry knows, that's not something people aspire to do. They don't want to get sued for reporting wrong information. But beyond that, the language of the rule itself really is actually impacting credit reporting agencies and lenders more so than debt collectors. What it really is doing is hiding that debt on a credit report, and it means that lenders can not have that information when they're trying to find out if someone can qualify for a mortgage or a car loan, because when they ask the credit bureau for that information, it's just going to be suppressed. So it's really not changing anything about the way the debt collection industry operates. It's really just hiding and suppressing information so that people are taking on loans that they may not be able to afford.
And Leah, let me just to add to that, when you and I and others were in Washington back in May, forgot what congressman it was. He was out of Texas, and he owns a bunch of car dealerships. And he completely understood and is completely against this because, to Leah's point, it's not so much the debt collectors as it is for the lenders. And what he said is, who's ultimately going to pay for this? Now that I go and loan money to somebody to buy a brand new car, and I no longer can see that they have never paid a single medical debt of over $100,000 in their entire life, and now I'm going to loan them a car without having that information. Well, what's going to happen is they're going to stop paying for that car. Car's going to get repoed. Who ends up paying for it? Us consumers. Interest rates go up, everything else like that. But before we continue on, Steve, I did see a question that I wanted to direct back to Leah, and that was from John saying, did the current administration gut the CFPB and suspend the rulemaking?
That's a great question. There's been over the past several weeks a lot unfolding, as I think everyone who watches TV knows, with all the agencies and DOJ and all of that. They did go into the CFPB. There was a directive when the Republicans took over. Originally, the first week of when the Republicans took over, it was Secretary Bessent, who's the Treasury Secretary, was serving as the acting director of the CFPB. He then passed that baton over to Russ Vought, who is the OMB director. They did send an email to CFPB staff essentially telling them to halt rulemaking activity and to halt policymaking and to halt a lot of the enforcement efforts that were going on. Some of that over the past week, because of litigation over what's going on, the CFPB has started up again, and there are certain functions of the Bureau that are functioning again. But from the administrative law process, an internal email telling staff to halt things really doesn't have the force and effect of law until there is an official change made in the Federal Register or through notice and comment rulemaking period. The rule itself has not changed. The only difference right now is that it is paused because of the litigation, and right now it's not moving forward in the original compliance date of March. And as I mentioned, that got pushed out 90 days. So the next briefing on that is due in June. As part of that litigation, the CFPB does have to provide a monthly report to the court, and they will have another one due in about 2.5 weeks in Texas. So it's kind of developing week by week what is happening there, and whether there's going to be changes made either through the administrative process at the CFPB, through the litigation, whether they're going to just settle the case and do away with the rule in that way, or if they're going to move forward and defend it. So we are working closely with the CFPB to figure out what's going on. We're working very closely with Congress. There's also 2 pieces of legislation challenging the rule, 2 congressional review acts, challenges coming out of the House and Senate, one introduced by Senator Mike Rounds and supported by the Senate Banking Chairman Tim Scott and several other senators, as well as Congressman Ralph Norman and 13 members of the House Financial Services Committee pushing back on the rule. So those are all efforts that are ongoing in different parallel tracks right now.
So quite a fluid situation. But as we stand today, the $500 and under is still in place, right? So we actually have another polling question. If we can show that polling question. Have the previous changes, well, what is in place today, have they impacted your AR days or recovery rates? Please log in your votes. So we had already heard kind of a preview of what the economist already said is yes, it will. And that was, Tim, just correct me if I'm wrong, but the economist was based on what was already in place, not in what is proposed in this, what we're talking about now.
Correct. And then he did have some overall predictions of how much this would ultimately cost healthcare providers over the next 3 years, 5 years, and 10 years. And I do not remember those numbers offhand, but they were monstrous numbers.
Well, yeah, I mean, if you take Dennis's number of 900,000 a month, almost $1 million a month, and you multiply that across all health organizations, is a very, very large number. All right, so here's our results. 53% say unsure. 26% said yes. 22% said no. So, okay, again, quite a fluid situation. So as we go to this, our next is, okay, Leah, you had already started down the path of saying, here's what's on the table, here's what's going on. You spend a lot of time, and I would dare say a lot of what you do is educate the policymakers, Tim, you as well, as to why this isn't the greatest idea in the world. But can you go ahead and expand on, well, tell me about the funding and the future of CFPB overall?
Yeah. Well, one thing is, as I mentioned, there's an acting director that has taken over for now, but there is a nominee for the full-time position who passed out of the Senate Banking Committee about 2 weeks ago. They're probably going to vote on the Senate floor on his nomination either this week or next week. So there will probably in short order be a new CFPB director that is going to be making more policy decisions on this issue and others. So that is something coming in the next couple of weeks. So something to keep your eye on as some of those developments happen. And your question about just, I think there's some overlap at the state level as well on some of these issues. And we're seeing a number of state regulations that are also targeting medical debt credit reporting. So right now, the litigation that is challenging the federal level rule, there's several components to it. There's some arguments about the fact that it rewrote the Fair Credit Reporting Act. So it was a kind of an overreach for what an agency is allowed to do compared to Congress. There's also some arguments about it being arbitrary and capricious, which they play into some of the numbers that Tim talked about the just billions of dollar impact on the industry without the CFPB having fully considered that in data and research. And then there's also one argument about the constitutional questions related to suppressing certain types of debt and not other types of debt. Here, the medical industry is kind of being singled out compared to other types of debt that are out there. Lawyers, for instance, when we ask our bills to be paid, if our clients don't pay them, we can credit report them still. But you guys in the medical industry cannot. So is that really fair to pick one profession over another? That's somewhat part of the First Amendment question that's being raised as one piece of the litigation. But the reason I raise that is that if that is fully litigated and considered, that is something that could actually impact the state level regulations as well, because if it's found to be a constitutional issue that people are not exercising their First Amendment rights, that would be something that would impact states that are doing the same thing. So all of that is fluid and playing out, and we're not exactly sure how all of that will go, but it's something that even if in the litigation that's ongoing right now, if that question's not solved now, I would venture to guess that someone's going to challenge these issues at the state level at some point as well, because of those constitutional questions. And I think it's going to be an issue that is being litigated and considered for several more months or years as people even more so figure out the impact on the credit reporting system and on the healthcare system. So there's going to continue to be updates, and it's going to be important to just stay informed on everything that's happening.
So Tim, we've kind of started this by talking about some misunderstandings in the proposed rule, and you talked about, okay, in that proposed rule, it stated, okay, not the exact words or verbiage, but it was, oh, errors in the statements are rampant. Well, that isn't true at all. Why don't you walk us through, you've spent a lot of time with the legislators, and this is probably where we get to, it's like, okay, well, we need to stay at the federal level, but also your state representatives need to know this too. Do we have a list of the states that actually have pending legislation right now or considering it?
Yeah, there's about, oh,
Well, there it is right there.
oh, perfect.
Yeah, California, Colorado, Illinois, New York, Minnesota, New Jersey, Rhode Island. They've already approved those. Delaware, Maine passed legislation, as well as Florida placed restriction on the sale of medical debt. Dennis, you had mentioned you had started this with, didn't make the list, but New Jersey is also in that list, correct?
Yeah, New Jersey is in the list, and we have 3 hospitals in New Jersey, and I'm sure it's not different in the Northeast than it is in the rest of the country. Hospitals are on the razor edge. You're either making a little bit of money, losing a little bit of money, hopefully not losing a lot of money. But anything that restricts your revenues is likely to push you over the edge. I'm concerned for hospitals throughout the state of New Jersey, our region of Pennsylvania. What we provide to the communities that's unique is our 24/7 emergency room. And our 24/7 emergency room is the costliest of our services. Because of the volume, its budget is the highest, and it has the highest percentage of uninsured patients because patients aren't getting primary care. They're not doing, diagnostic testing. They end up getting sick, coming to the emergency room. And as we teeter, on that edge of making money, losing money, you just continue to see more hospitals shutting down services, more hospitals shutting down entirely. And it just hurts the whole system overall. I think that's the impact that we're under threat of seeing in New Jersey as well as Southeast Pennsylvania.
Yeah. Kind of deviating just a little bit, but one of the questions that just popped in was, well, it's not really common. They don't credit report. Not familiar with many that do, and that's our case. And most, I can't imagine. I mean, we work with a very large number of hospitals, very, very, very few credit report, and they haven't for quite some time. But the issue, as we've talked about before, was it's just public knowledge that you won't credit report, because ultimately there was this, even though your hospital didn't credit report, there's this message in the back of their mind that they think, oh, I don't want this to impact my credit. You never say you're going to credit report. You never tell them that, any in written or verbal, but they still have this perception. Well, now that perception's gone, and you don't sue. So it goes back to, well, then what leverage do you have?
That's all true. Yeah,
Yep.
there's very little leverage, and we have tactics to try to cope with this, but there's on the back end, when you're sending a bill, when you're making a phone call, sending a text, you have very little leverage. And just to go along with that, Steve, it's not just the leverage for the collection of that bill, but it's the priority. It's the priority of the bill. Everybody has their monthly bills to deal with. They have their mortgage. Their kids are in college. They're making a car payment. And as you're stacking up the bills on the 27th of the month and you're going to write a bunch of checks, where does the healthcare bill, where does the hospital bill go? It goes on the bottom. Yeah, it sinks magically to the bottom, like that ace of spades when they're doing card tricks, goes right to the bottom there. And, if there is discretionary money at the end of the month, or somebody has a great moral obligation to pay their bills, you could get paid, assuming the balance isn't too high. But, in many cases, it just doesn't get paid at all.
Exactly.
So there's a comment here about upfront payments, and that we have seen already start, and especially for specialty healthcare, we're seeing, and again, so I can't even get, say, my child in for service until maybe it's as much as $1,500, maybe it's $2,000. And so going back to your thoughts on your comments, Dennis, so now I have a mortgage payment, now I have a car payment, I have all this, but I got to pay $2,000 up front to have my child seen for specialty care. And so, but there was an article, I think it was in New York Times or Wall Street Journal, 3, 4 months ago that there's, I think, 528 more facilities across the country just over this past year that are charging up front for non-emergency things. One of the mistakes, kind of going back to your question, Steve, about, how did we get here, is the CFPB never reached out to talk with medical providers, revenue cycle experts, our industry from the collection standpoint. We have requested multiple conversations with the previous director under Biden's leadership of Director Chopra. Never once would he talk to us. And so that is when you're making strong policies, you need the experts at the table. And they did a lot of this on speculation. Now the CFPB has unlimited funding. They have so much money they spend on research and development and pay a lot of people to do all this. But again, they never came to talk to the people that are in it day to day.
Yeah.
Well, having said that,
and Tim, I want to credit Tony Murray in the chat over there.
Yes.
About the upfront payments, and he's stolen one of my bullets for our wrap up. But I really do think that is, the one of the most significant things you can do, in this time of, regulation of self-pay payments, is while you have a little leverage, even if it's just a perception, certainly for elective services, you do have the option to postpone or cancel services, if the patient is not going to be able to pay the balance. One thing we want to do, it's kind of a two-step process, is how many times, and to the general audience, do you hear from a patient, I had insurance, I had no idea it was going to be this expensive. And it's not the hospital assigning the cost to you. It's your insurance. It's your insurance plan. You selected a lower premium so that you would have a higher deductible. And that's, now it's time to pay the piper, kind of. We want to communicate a time of scheduling, and time of service. If we're not collecting, we're at least making them aware, of the debt. Insurance companies can take 6 months, 9 months to pay a bill. People think they got off, like, well, I never saw a bill from the hospital. Well, that's because we're fighting, to get the money that we're owed by your insurance company. But 6 months later, 9 months later, when you get the bill, you hate to have that person say, I never expected this. I never knew this was coming. You want to make sure that they know from the beginning, and not just let them know of the potential debt, but try to collect that debt.
Yeah, the use of bill estimation tools, telling them up front what their responsibility would be, being able to verify their insurance or eligibility for the insurance, and understanding what their deductible is.
Sure.
Having said all that, we do have another polling question. And that polling question is, what is the biggest challenge your organization faces regarding medical debt and credit reporting? Or better said, maybe, what do you find is the biggest issue that you have with the self-pay receivable right now? Lack of clear guidance, compliance with new regulations, educating the consumers, or other? Dennis, you want to tell us a little bit more about, upfront collections? What else are your thoughts on this subject?
Well, that's a big part of it. I talked about making patients aware of the costs, and Steve, it is easy relatively for patients who are uninsured, because you'll have a self-pay rate. It's based, usually on your most common commercial reimbursement, or your Medicare reimbursement, or your Medicaid reimbursement, times a certain percentage, a certain markup. It's something very reasonable that takes you well down from your charges. Self-pay estimations are relatively easy. What's difficult is dealing with the out-of-pocket costs, because payers don't have or share maybe up-to-date information. It's difficult on the staff that's trying to find the amounts due, because there's multiple payers, and within each payer, there's multiple plans, and within each plan, there's multiple options, your platinum, your silver, and your bronze, plans that have, different features that control the out-of-pocket costs. And that's really, really difficult sometimes.
Yeah.
We will try to collect, and we are going to do our best to improve our technology, in determining the amounts after insurance payments. But we also want to make it easy to pay. We just found, our organization just found that 42% of our self-pay payments are coming through our portal. And we're an Epic system. And, Epic has a very advanced tool in MyChart. And our patients are getting more and more engaged, in using MyChart. But we've implemented kiosks in multiple locations, so that we can ask for, as people are doing what is basically a check-in at the kiosk, they're asked for their, at least their copay. And if we know their coinsurance amount, that comes up too. So, we're trying to make it easy to pay as far as, technology. We send text to patients. We use the kiosks. We have a portal, and we accept various means of payment. It's not just American Express, MasterCard, Visa anymore. We'll take Apple Pay. We'll take Venmo. We'll take Zelle is Bank of America. But, we're trying to expand our payment plans. We have patient financing at zero interest. For that you can really set that up before your care so that you have that load taken off your shoulders. Anything we can do to make it easier for the patient to keep those accounts out of bad debt, we'll do.
Perfect.
Hey, Dennis, I don't know if you talked to Tony beforehand, but Tony just took up your other bullet points. And his comment, I won't read the whole thing, but the last comment was, heck, let the payers collect the patient portion. And we just talked about that.
Yeah. And as we look at our crystal ball and try to figure out what the future is going to look like, that's one of the things you've heard about. Actually, I can tell you, I'll mention I won't mention the insurance company because I don't want to get in any trouble, but it's actually a very good thing. There was one of the bigs, insurance companies out there actually have a plan where they will not only they'll pay the hospital, the rate, and they're settling up that out-of-pocket cost with their patients. And as they're doing that, they're adding a financing component to that so that the patient can get that, and I assume it's 0% interest, I don't know for sure, but they can get that, long-term payment plan, a financing plan from their insurance company to pay their out-of-pocket costs. And I hope that's a trend that catches on.
So I'm sorry, I was neglectful in telling you what the polling question was, but the leader was educating consumers. That was a 47%. So,
and Steve, we say that all the time. I mean, our job, I always laugh, and I travel a lot, obviously sit on airplanes, and you always get like the person next to you. So what do you do for a living? Nothing better than telling people you're a bill collector. But once you start explaining the medical side of it, and we really are educating people, and especially you talked about high deductibles. Over the years, since high deductibles have become more and more popular, our average phone calls used to be 3 to 5 minutes with patients or consumers. Now, there can be ones that are 45 minutes to an hour because you're walking through each and every charge and explaining. Many times we're getting the insurance company on the call with us to walk through. So, but our average call length now is, I think it's 9 minutes. And so, again, doubling just over the last 10 years.
Yeah, so wrapping this up, we're now at the next stage as well. Okay, so you've heard, most of you agree, this is an issue. So what now? Well, let's just say, Leah, that this whole credit reporting thing is put by the wayside. Unless the media is aggressively saying, okay, credit reporting's back, it's like you can't put the genie back in the bottle, or the well's already been poisoned. It really is going to be an issue. And then you talked about the state issues. Even if the federal issues are resolved, Now what, right? So it's at the state level. So what are some of the things that we talked about? Pre-collections, we talked about legal, we talked about, okay, well, what if credit reporting is resuming? What do we do? I think if you say, well, here's the ask, it really is to make sure that each and every one of you is really involved in the process. I started this by saying, a lot of what was proposed in the rulings was just a plain misunderstanding. And it almost discounted everything that health hospitals are already doing. Dennis had already mentioned the self-pay discounts that exist. Every statement, or most every statement, has a plain language summary for the financial assistance policies. Okay, well, that was never entered into the equation from the CFPB. It was really just all the bills are wrong, and therefore, your people are paying $35,000 and bankrupting. It does dismiss a little bit that healthcare organizations are compassionate. That is their mission, is to treat patients with dignity and respect, and that is done. So as a last thought, let's have one more poll question, if we could. What additional information would be most helpful to you? Okay, you get one choice. Here it is. More details on regulatory updates, best practices for compliance, or consumer education strategies. Which do you believe would be the easiest or most appropriate?
Steve, as we wait for this question, there was a couple comments, and one in the Q&A and one in the chat here, but mentioning what percentage of healthcare organizations across the country credit report, because they have it in years, like Dennis and many others. And so I don't have that exact number, but I can tell you, since, again, over the last 3 years when this started to be talked about, a lot of our large health systems that used to credit report told us stop. And a lot of them also stopped during COVID and then never re-engaged. And but the other thing is, the smaller rural community ones, it really benefits them. And that we talked about, Leah mentioned how this is going to impact, and we've already seen it impact in the rural communities and the communities serving the underprivileged and minorities. Those are the first ones that are going to get hit here. But overall, as a company, I think, Steve, it was probably 10 years ago, maybe 12 years ago, we were not one that credit reported, or we didn't recommend credit reporting, because that's the number one ways to create disputes, create lawsuits against us. And when we did the first study, we saw a dip, but it wasn't all that big of a dip. And I think the difference is, if they wouldn't have gone out and advertised the heck out of this, saying we don't credit report, and that's back to my earlier comment. So, but I do feel it will, and we are seeing it hit the small rural communities, and it could get worse.
Interesting.
Yeah. And Tim, I wonder what the breakout is with nonprofit versus profit in
Without
systems.
Without a doubt.
And you would think that the nonprofits reporting to credit agencies, it's got to be pretty close to zero. If there's a significant measurement of institutions that are credit reporting, I would think it's in the for-profit area.
Yeah, it's a low. I would agree that it's a very low number. Hey, our polling question, it's basically a three-way tie. So yeah, so I find that very interesting. So all of that. Let's see, in the webinar chat, there is an evaluation form or in the chat section, there's an evaluation. I would just say fantastic is the way that you want to evaluate it.
Can I take this moment, Steve, to mention the story about Cyrus the dog was completely made up. I saw a lot of comments in the chat. Everybody feels bad for the poor dog. Poor me. What if I had a broken hip? There were no broken hips. No schnoodle was injured in the construction of this scenario here. It was totally just to make a point.
There you go.
So,
we do
Steve,
have a couple.
Oh, I'm sorry, real quick. You mentioned what can we do, and it is getting involved, getting involved with your trade associations, getting involved with your state and federal regulators, members of Congress. They do listen. Leah is on the Hill just about every single day, and I go about 2 or 3 times a year. Have a lot of friends there. They understand us. They get it. But more importantly, they want to hear it direct from you all. And so if anybody's ever interested in wanting to get in touch with somebody in DC or on the state level, we'll have our contact information. Feel free to reach out. We would love to introduce you. We'd love Leah and her team at Brownstein could help set up that meeting. I could help set up that meeting, but it makes a difference. Now, it's the landscape has changed. I mean, we've spent a lot of time on the Hill. Lee and I actually were at the White House twice. The first White House meeting, they gave us the full hour, actually a little over that hour. Last spring, we were there this past May. They already had their mind made up. They were ready to drop that proposed rule, and they did drop it about 30 days later. And they gave us about 10 minutes, and they said, oh, the conference room is going to be used. Well, right outside the conference room, it showed the schedule for the day. It showed us for the whole hour. They just didn't want to hear it anymore. But getting involved. So that's just how I'll.
Yeah. I would just add to Tim's point, in some of this discussions recently, there's a letter circulating in Congress that a number of the healthcare trade associations signed on to, the American Dental Association, HFMA, AHAM, several others in the medical space. That really was helpful to some of the conversations to have that voice at the table. As Tim mentioned, the CFPB tried to sort of gloss over the fact that medical providers were impacted, and because of that, people didn't necessarily have an opportunity at the front end to weigh in on the impact here. But people on the Hill are looking for feedback on, particularly, we keep talking about rural and underserved areas, and different types of health providers that have all different types of services around the country. They want to know about that because that is something that they want to protect, and they want to make sure that you guys are being treated fairly and that you're able to run successful practices for patients. So all of that information is very welcome in DC, and it never hurts to just tell the truth and to talk about how things are impacting you.
And I'll add one last thing, and it's, where does this stop? So if we allow this to go through, what industry are they going to pick on next? We know, the last administration was trying to get rid of student loans. So now I don't have to pay a student loan. I don't have to pay my doctor anymore. When do I have to pay for my house? When do I have to pay for that new car? And when am I have to pay for my cell phone? I mean, and actually, a member of the CFPB did tell me the next move that they were prepared to do with the old administration was look at telecommunication, Wi-Fi, internet, and cell phones not being credit reported. So, but this is America. We're in a credit-based economy. We're a very successful economy, but that's because the rules and policies we put in place.
Couple real quick questions. We got 1 minute left, but is mental health and behavioral health included in what is currently on tap? Leah?
Yeah, it would be, yes, if it's provided by a medical professional to a human person, or that's not the exact word they use, but it would be.
To an individual. And is it $500 per provider, per visit, per claim, per day?
Yeah, per instance. So yeah, per visit.
Okay. Well, it looks like we're at the top of the hour. Here again, fill out that evaluation form. There's the meeting code. We had a slide up that we will be doing a presentation at the annual conference on the 23rd at 9:10 in the morning. Great time. For those of you that will be in Denver for the annual conference, I hope you'll be able to join us. Thank you all.
Great. Thank you.
Thank you, everybody.
And with that, we have reached the conclusion of today's webinar. I would like to thank our speakers and state collections for sponsoring. We hope you found the presentation informative. Thank you for your participation and have a great day.